I'll start. So, good evening and welcome all to the fourth episode of the Maha IP Case Challenge Academics. I welcome all the dignitaries who are present on the Zoom dais as well as those who are watching on the YouTube live. We are happy to have with us Maha IP President Dr. Hemant Gangolia sir, Dr. Amol Pawar, who is the Secretary, and our expert today is Dr. Rajendra Vaidya sir, Dr. Mohite sir, and of course the enthusiastic Kolhapur team and the Hingoli team, and the moderators to Dr. Tushar Muniyar sir and Dr. Vipul Patil. And I welcome all my dear colleagues and friends to this academics today. And now I will invite Maha IP President Dr. Hemant Gangolia sir to give his opening remarks. Over to you, sir.
Thank you, madam. Good evening and namaste to our expert, Dr. Rajendra Vaidya sir, two presenters, Dr. Tushar and Dr. Vipul, and two enthusiastic teams, Kolhapur and Hingoli, to this fourth episode of Maha IP Case Challenge. And I'm sure with these two interesting cases coming on, all the best wishes to both the teams, and let us sail through the two interesting cases to get the clues in our day-to-day practice how to go about it. Thank you very much. All the best.
Thank you so much, sir, for your crisp remarks. Now I will request Dr. Mohite sir to give his comments. Sir, unmute yourself, please.
Thank you very much, Dr. Sunita and Dr. Hemant. I think we are, as Hemant said, this is the fourth session. And so far, we have already gone through 6 cases in the past 3 sessions. And the enthusiasm is still maintained. And I'm sure it's going to be really a challenging session. Usually, we are able to circulate these flyers late simply because it's kind of a secrecy we maintain. Till today, perhaps, the Hingoli team did not know who is going to present to the team. And Kolhapur team still don't know who is going to present them at this point of time. Okay, just now I told we put a cheat here and I told Dr. Sunita Ingai who's going to present whom. Obviously, they cannot circulate, and today morning or maybe last 2 days they must have said you're going to take a case and you're going to present. Okay, so that kind of a secrecy we maintain this, and this is only to sort of make it absolutely academic approach wise case, and the cases which are selected are clearly based on clinical approach, nothing very kind of extant. Again, I am repeating, diagnosis is not important. It's how you approach, what logical approach you give to, that's going to be most learning point. So without wasting much time, I hand it over to Dr. Sunita Ingai to take it further. Thank you very much. And I'm seeing good, nice seniors here. Mahesh, my friend, is there, sitting exactly in the middle. Mahesh, doka sampurna safed zale. So I sense the aging on my end also. And of course, the other colleagues, great to see you all, and great to see you all taking the challenge. Actually, it's already really a great effort on your part to sit with the courage on this. You are sitting in a hot seat, mind you. The fact that you have chosen to sit there, that itself says that you are one. You will require a lot of courage to sit in that seat, believe me. And so, all congratulations to all 6 of you for accepting our invitation and taking the challenge. Don't take it as a challenge. Your approach. You are teaching so many people today, and many will be accessing later. So that's what you accept. Thank you all for joining it. Thank you very much. Over to Dr. Ingray.
They are sitting together for the moral support also.
Thank you so much, sir, for encouraging the participants. It really takes courage to be in the hot seat. Now it is my pleasure to introduce today's expert, Dr. Rajendra Vaidya sir, who is from Aurangabad. Sir calls himself a preventive and primary care pediatrician, and he's a senior person who's practicing at Vaidya Children's Hospital in Aurangabad for so many years. And sir has been the Maha IP president in the year 2017, and also has been the election commissioner of West Zone Central IIP in 2018-19 and 2020-21. Sir's main area of interests are of infectious diseases, vaccinology, pulmonology, hematology, neonatology, and rheumatology. Now, I will request Dr. Rajendra Vaidya sir, to please come in and say a few words. Over to you, sir.
Oh, okay. Good evening and thank you. Thank you, Maha IP, Hemant sir, Mahesh sir, and Sunita madam for inviting me for such a wonderful Maha Case Challenge. It's a real challenge for me also. because when I gone through the 4-5 episode, when I attended also, the experts are so stalwarts. So I am a very small person in front of it. I confess, I am totally don't have any teaching experience. What I am purely practicing pediatrician. So may not be like a typical teacher. I'll be able to say few things accordingly. But what with my experience, definitely I will try to give justice to whatever job you have given me. And I really appreciate it. My aim guru is Dr. Ambedkar sir. Almost everybody's guru is there. I know I have learned a lot, but only difference is that I was never his student directly for PG, undergraduate, anything. Which I never attended this clinic or never anything happened. But only in the conferences or with the personal relations, I have learned a lot. Like Eklavya, I learned a lot from him. He's a Dronacharya for me. But base part of it is that the Dronacharya has asked thumb. अंगठा तरी मागितला होता एकलव्याचा. आंबेडकर is such a great person. The sir whatsoever one सांगता मागत ते is a great service that I am very admire and really thank Mahesh and everything. Both Mahesh Kore and Mahesh Mohite is there. Tushar is there. Really, I am very proud and really I am going to learn a lot. As an expert, I may give some point, but I am going to learn a lot. Thanks a lot. All the best for both the teams and we'll continue. Thank you very much.
Thank you so much, sir. Experience is indeed the best teacher. I'm sure you will do. Now, for the further proceedings, I will hand over to Shilpa. Shilpa, please go ahead with the teams and announcing the moderator.
Good evening to all the seniors and colleagues. Thank you for joining with us today. So before we go, I'll just quickly say the rules. So each case will be given 25 minutes for the presentation and discussion, and the next 5 minutes will have our experts' opinions. And request all the others to keep themselves on mute. Only the team who is being asked has to be on unmute, and the moderator has to be on unmute. Rest everybody will be on mute, and you should not be typing any answers on the chat box. Requesting it to everyone. Okay. So our two moderators for today are Dr. Tushar Maniyar sir and Dr. Vipul Patil. Dr. Tushar Maniyar sir is the head of Department of Pediatrics, Nanavati Max Super Specialty Hospital, Mumbai, and he's the director of Maniyar Clinic in Andheri. And he's also a great teacher and have contributed in training of pediatric residents. Our second moderator for today is Dr. Vipul Patil. He has been trained under Dr. Mahesh Mohite sir and still continues to work as a consultant at Sai Child Care Clinic, Panvel. So our teams for today are from Kolhapur and Hingoli. From Kolhapur, we have with us Dr. Mandar Patil sir, Dr. Venkatesh Tarsban sir, and Dr. Mahesh Kure sir. And from Hingoli team, we have Nitesh Chaudhary sir, Swapnil Giri sir, and Anand Meni sir. So our first team for today will be team Hingoli, and Dr. Tushar Maniyar sir, I request you to please share your presentation and start the case.
Thank you very much. Thank you, Maharashtra IAP and Dr. Sunita Ingle, Dr. Hemant, my dear friend Mahesh, and Dr. Rajendra, Dr. Shilpa, and everyone else. I will start sharing the screen, and without wasting much time, what I wanted to say is that let me just.
Slideshow.
Yeah,
Slideshow. ऊपर देखो ना slideshow. Animation के बाजू में slideshow.
This Zoom is covering it up.
हाँ इधर नहीं, हाँ नीचे भी करेगा, चलेगा, नीचे भी चलेगा. You can come down. हाँ there. Just double click it. Double tap करो. Yes.
Okay, thank you for your help. So first of all, I must say that I am very lucky to be on this side of the table, and I must say that the team who's sitting across is very brave. Somehow I would like to pin the team so I have some visual connect. Can I do that? Hingoli team, I'll try and pin you so that we can see each other. Yes, thank you. So important to remember, as Dr. Mahesh said, this is whatever we do deal in day-to-day life. And please, I would appreciate you discussing. I won't even say answer or challenge or quiz, discussing the case along with me on your clinical approach. And as we say, the journey is as interesting, should be as interesting, or if not more, than the destination itself. Okay. So let's look at this. This is an 8-year-old girl brought with fever for 5 days, neck swelling for 3 days. Fever was low grade. There were no chills. It was intermittent. No major change of pattern over 5 days. And it used to respond to paracetamol. Okay. Just to repeat, 8-year-old girl, fever for 5 days and neck swelling for 3 days. You can take your points over there, no problem. About the neck swelling, the parents reported that they have noticed it for last 3 days. It has increased over 3 days. It's not very painful. No redness has been observed, and it's on the left side of the neck. On examination, we found it to be 2.5 centimeter in long axis. It was firm to touch. There was minimal tenderness when we were trying to palpate it. And overlying skin was thin. It was mobile and not fixed.
Yes, sir.
Okay, sir.
Okay, sir.
Okay. Just to give you other ideas, normal milestones, adequate diet, fully immunized. There was a history of neighbor who has completed treatment of cock spine successfully 2 years back. And socioeconomically, they are upper middle class. The other examination-wise, child was having stable vitally. Anthropometry was between mean to +2 SD. A BCG mark was seen. No other stigmata of any kind, tubercle, neurocutaneous, or any kind of rash, etc. were noted. No liver and spleen enlargement and no other significant lymphadenopathy was noted. A systemic examination was also at this point in time not contributory. Okay. So my question is, do you need any other information at this point?
Yeah, is there any past history, sir?
No significant past history. Child was apparently normal before this episode. No major illness in the past. Okay.
Yes. Okay.
I would just suggest that let's not overthink and think that I'm presenting something really awkward. There is routine stuff what we see in day-to-day life. What is your clinical impression at this point in time?
Sir, 8 years old girl, healthy girl from
Yes.
Middle class, like well-to-do class, and on examination she's healthy, and plus she has received all the vaccination previously, and nothing past significant history, or it's a acute episode, fever for 8 days and then the next swelling for 2 days, 3 days. It's progressively increasing swelling, right?
Fever for, I think we said fever for 5 days and
Yes,
neck swelling for 3 days.
Yes, sir.
Okay.
So considering the possibility, first, like it may be a acute infectious infection, fever followed by the simple lymphadenopathy of the neck, like acute lymphadenitis, or maybe some throat congestion inside, like tonsillitis followed by the lymphadenopathy, or some like abscess kind of thing. Also, one of the possibility, parapharyngeal abscess and all that can also cause fever and
Yes.
neck swelling, sir. So
Okay.
these are the one of the primary possibilities.
Okay.
And,
So let me ask you this way. Do you think this is a non-specific lymphadenopathy or significant
No,
lymphadenopathy?
sir, significant lymphadenopathy.
Significant, very good. Do you think this is likely to be a bacterial etiology, as in an acute, like non-tubercle bacterial etiology or bacterial tuberculosis?
Bacterial, sir, but the fever is low grade. So sometimes it can be tuberculosis also. The starting of tuberculosis, there is a low grade fever is there. So I think it can be a tuberculosis also.
Okay. But can it be bacterial or not?
bacterial, or viral, even viral also.
Okay. Do you think this can be Kawasaki with a lymph node fever for 5 days? Lymph
So no,
node
sir.
for-
Lymph node, Kawasaki will have high grade fever and almost continuous fever.
And age group is not matching, sir.
No,
Kawasaki will present at 5
Excellent.
years.
Excellent. And no other sigma that we have seen till now, at least. TB you already mentioned, correct?
Yeah.
Anything else it could be?
Can be malignancy also, start of malignancy also, sir.
Okay, excellent. Okay. So let's see, a patient had come actually with this CBC report which was done on the previous day. Hemoglobin was 11, MCV was 78, WBC was 6,000, neutrophil count was 55, lymphocyte 55, sorry, 45 it should be. Lymphocyte is 45, neutrophils were 55, platelets were low normal, 1.6. And no other investigations have been done till now. What will you do next?
Examination, physical examination.
Physical examination findings, I'm sorry, I thought I had mentioned clearly. Let's repeat one more time for you.
Yes.
Vitals are stable, anthropometry is normal, BCG mark is seen, no other contributory finding. No liver spleen, and lymph node description I have written here, 2.5 centimeter, long axis, firm, minimum tenderness, overlying skin was thin, and it was mobile.
Yeah.
Anything else you need?
It can be other also, sir. Mycoplasma or brucellosis also that can present as like a fever with lymphadenopathy. Other things also can be.
So what would you want to do now?
Yeah, we can go for sir FNSC or biopsy, or we can give first trial of antibiotics there. If they
Okay, very nice. So what antibiotic would you choose?
Amoxiclav or azithromycin. Azithromycin also. Yeah.
For 5 days and then wait for response.
If you use amoxi or amoxiclav, what will be the dose that you would use?
Yeah, 40 milligram per kg per day into 2 to 3 divided doses, sir.
Okay, excellent. So this patient was started on amoxicillin, 50 milligram per kilogram per day, was advised for 10 days. Okay, as you chose to do that, because patients were, as you said, we'll give a trial of antibiotics and see. Though you had mentioned that doesn't look like acute bacterial. Which antibiotics would you not use at this point?
Clarithromycin also.
Do you not use, I'm saying. Okay.
Any antibiotic with anti-tubercular properties.
Excellent. Very good. Excellent. Now on day 4 of antibiotics, fever pattern was same. So remember, we said 5 days of fever to start with and another 4 days on antibiotics, total of now 9 days of fever. The lymph node size had slightly increased from, we said earlier, 2.5, now it has become 3.5. There is still no redness and no new lymph nodes noted. There is no pain also. And on examination, the remaining findings have remained same. Would you change the antibiotic, and if so, to what? Which antibiotic?
So we'll work up.
Azithromycin, sir. Azithromycin can be because it covers the atypical organisms are there, as like mycoplasma, and we can give also doxycycline that can cover the brucellosis also.
Okay, okay. So I would have said probably that at least in this patient, we did not change the antibiotic. We continued, but as you had just said, we wanted to do more. Okay. So what other differential diagnosis you think of, and what are the reasons for considering other? You already mentioned brucellosis, but as we said, there is no exposure history, no travel history, no liver spleen. So, and it's a bit too early to start thinking of brucellosis, right? I mean, fever has not become more and there's been a single lymph node, no other joints or any other illness.
Right now, subacute presentation is there. Right now, sir, fever is continuously running. Lymphadenopathy size is increased, so it is subacute, going towards the subacute presentation is there. So the things are there right now. Tuberculosis can be there, or it can be malignancy is there. These two things.
Okay. So what investigations would you like to do at this point in time?
CBC, we'll repeat the CBC. We'll go for ESR.
Okay.
And then chest X-ray.
Okay.
Montus test.
Okay.
And
FNSC, we will go for FNSC.
Okay.
If presents
anything else?
Lymph node biopsy we can do.
FNSC or biopsy? We'll discuss that.
Biopsy is ideal, sir.
Biopsy is
Biopsy is
ideal.
gold standard.
Why biopsy? I mean, if you can get something simple with FNSC, I mean, what I'm asking you, what are the advantages and disadvantages or limitations that you would consider when you take a decision for FNSC versus biopsy?
Biopsy will give definite diagnosis, sir. As like a malignancy, we can diagnose with the biopsy there. FNSC will not give the diagnosis of malignancy.
Excellent.
So we can do that.
Any other test right away you want to do? It's okay. It's not like one time, right? You are managing a patient. You will get an opportunity to do other things later on. But suppose I'm just asking you, in case some of these were present, how your thinking would have changed is what I wanted to know. If there was weight loss, how much weight loss would be significant? When would you worry about a weight loss in this child?
10%.
Okay. Okay, 5 to 10%. Yeah. Suppose there were night sweats. What other diagnosis that you would consider?
Tuberculosis.
Sorry?
Tuberculosis, sir.
Tuberculosis, yeah. It's more common in adults to have this history of night sweats. Anything else with night sweats? It's okay, that's fine. We would think more of tuberculosis. Suppose it was an irritable child, we already discussed that, right? But suppose there was associated hepatosplenomegaly also, then what else would you how your priority would change?
Yeah. Tuberculosis will not present with HS megaly, sir. Most of the time, unless and until it is going towards a systemic concept. So it will be go towards the malignancy right now.
Excellent.
Or a typical infection that can be present with a lymphadenopathy along with HS megaly.
Absolutely. But just to make it clear that none of these were present for our patient. Okay. This is just to ask you, if there were things present, what would you think about? Okay. What is the role of CBC in differential diagnosis now that you are on day 8, day 9? If you do a CBC, what would you be looking for? Simple things first, right?
Increased WBC counts, sir.
Okay, very nice. What else?
Dropping in hemoglobin. Like
in which condition?
Chronic infections will have.
Okay.
And neutrophil and lymphocytic ratio, sir. Right?
For
atypical infections like infectious mononucleosis will have atypical lymphocytes and.
Excellent. Okay.
Lymphocyte counts.
Yeah.
Suppose WBC and platelets both were dropping.
Then we have to consider for malignancy also.
Absolutely. So nice. So we did a repeat of this one. My math, somehow this one doesn't seem to be good. It's just going to 110, the total. So just pardon me on that. Hemoglobin remains same, MCV remains same, WBC, neutrophil, platelet, more or less the CBC was same as it was on day 4 and now it is day 9. CRP was 20, normal being 1:2 from 1 to 5. ESR again 20. Okay. Mantu, 1 TU given 10 by 12 millimeters. This is an 8-year-old child and a BCG mark is seen. IGRA was also done, which was negative. Gene expert for sputum. We have not yet done the biopsy. This is sputum where no MTB was detected. And chest X-ray standing AP or PA was taken, which appeared to be normal. We also had done serology because we are thinking to rule out other conditions. They were not willing for a biopsy straight up. So they wanted to wait few more days on antibiotics. So serology for, as you said, EBV was done, CMV was done, HIV was also after counseling was done and was normal. LDH, uric acid, peripheral smear to rule out at least some signs of malignancy was done, which were normal. Now we asked for a sonography of the lymph node. So tell me, what are the characteristics of sonography? Do you have any thoughts on how it would be different in Kawasaki, in lymphoma, and in bacterial infection? What would you expect on sonography? If you don't do routinely sonography for this, it's fine. You can say pass. There's no problem.
Kawasaki, sir, there is a unilateral lymphadenopathy.
Yes, absolutely. And they describe it as small, it's like a bunch of grapes appearance, so multiple small lymph nodes are there. In lymphoma or any malignancy, instead of oval, you see more circular lymph nodes. You see them to be firm and you see a hilar perfusion on the ultrasound. For bacterial infection, we know that there may be abscess formation or fluctuation and probe tenderness at the time of when you do this sonography. For our patient, this lymph node on sonography measured 3 centimeter in long axis. It was a single oval, showed some necrosis and fluctuation. They were not sure whether it is positive or not. Okay. Have you taken note of these findings?
Yes, sir.
Let's go to the next page. So then biopsy was decided, and as we discussed, the first question was whether to do FNSC versus excision, and all of you have voted for excision, which is what I would have also thought of. But suppose there was more than one lymph node, how do you choose which lymph node to excise? Sorry?
Large one, sir.
Large one. Suppose there were cervical, axillary, inguinal, cervical, axillary, supraclavicular, inguinal, all 4 generalized lymphadenopathy was there. Which area would you choose?
Supraclavicular.
If there was only axillary, cervical, and inguinal, what would you choose?
Axillary.
Okay.
Yeah.
So the correct approach would be probably, first of all, the principle is choose the most abnormal looking lymph node. So largest is correct, most formed lymph node, if they are similar size, that also is appropriate. Supraclavicular always stops because that is most likely to yield. But between cervical, axillary, and inguinal, usually cervical is preferred, except for the fact that it leaves a cosmetic mark. There are no neurovascular bundles, and the yield of cervical is better, ease of access is better. So that is why that is preferred. We will not discuss that because you've already chosen excision biopsy. Now you have done a biopsy. What would you want to send it for?
Histopathology.
Okay, excellent.
ZN staining, gram staining.
Okay.
CBNet.
CBNet, very good. And one more.
Culture.
Culture, correct. Excellent. So we did that. We did an excision biopsy. Gene expert was done. Mycobacterium tuberculosis was not detected. Culture and histopath was awaited. What are your thoughts now? You are waiting for the histopath report to come. What would you be doing now at this point in time? What is your working diagnosis?
Tuberculosis is rolled out, sir, right now because gene expert is negative. So
okay.
It's going towards towards a malignancy or atypical infections are there.
Okay.
We are thinking about that.
Okay, excellent. You did a histopathology report you got. It showed a 3 centimeter lymph node as was seen on the sonography, and AFB were present. Non-caseating granulomas were seen. Irregular, ill-defined granulomas were present. Polymorphonuclear leukocyte in central areas of necrosis. There was suggestion of chronic inflammation, and multinucleated giant cells or microabscesses were seen. This is the report of histopathology. What do you infer out of that?
It can be a bovine tuberculosis also, sir, because AFB is present.
Correct. Excellent. So you are saying this is likely to be not Mycobacterium tuberculosis, but something like a bovine tuberculosis. Is that what? Is that right? What you're saying?
Yeah, just we are suspecting it.
Correct. So that is your diagnosis. What drugs would you like to use? It's okay. It's not like we come across bovine tuberculosis every time, every now and then. So don't worry about that part. Would you do notification in this patient?
Yeah, we have to notify.
Where do you notify?
Same, sorry.
District tuberculosis officer.
What is the program called?
RNTCP.
RNTCP.
Okay. It's now called as NICSHI. Now, this is a bonus question for the audience. If the organizers permit, I would allow them to write on chat box. What does NICSHI stand for? It's okay. This is not for the team to answer. So, I mean, if you answer, very good. But otherwise, I want people on the chat to answer if they can.
Of the Kshay Rog.
Sorry?
Elimination of the Kshay Rog. Kshay.
Correct, absolutely. Ni is end and Ksha is TB. Very, very good. Dr. Deepa has answered and so has the team. I'm so proud of you. Okay, so Nikshay notification. What is Nikshay Poshan Yojana? Any idea?
500 per month given by government to the patients.
Absolutely. So they need to register and then they get 500 rupees for their dietary, as a dietary allowance. And just for other input, if you are from a tribal area, you even get 750 rupees travel allowance.
Yep.
What is the penalty for non-notification? I'm very happy that you said notification. Otherwise, I would be very worried. The maximum penalty can be jail term. Okay, one can be jailed if we have not failed to notify a case of tuberculosis. Okay, so now answer this one for me. Is this Mycobacterium tuberculosis or is it non-tubercle Mycobacterium?
It's non-tuberculous.
Excellent, brilliant. So we are waiting for culture. So let me ask you one question. Why do you think it is a non-TB, non-TM? Your AFB is present, you have necrosis in the center. So what are the clues that tell you that this is likely to be non-tubercle Mycobacterium versus a Mycobacterium tuberculosis?
Gene expert.
Gene expert is negative, sir.
Gene expert is negative. Okay. What else? Your thinking is very correct. One more area where there was a discrepancy, if you remember in the previous tests.
Matted lymph nodes.
Mantu was 10 by 12. Mantu was 10 by 12.
In tuberculosis, matted lymph nodes are there. 3 to 4 kgs.
What was the Mantu report?
10 to 12.
10 to 12.
What other test we did for TB?
X-ray test is negative.
MTB and sputum for AB and this one.
Any clues here? It's okay. Mantu positive and IGRA negative is a red flag. Okay. Mantu positive, IGRA negative is also a red flag, just as you got AFB on histopath with a gene expert which is negative, correct? So now you're thinking of NTM while waiting for culture. You already sent for MGIT, right? What would be your advice? What would be your advice? You have done well. See, you already diagnosed it correctly. You answered all the questions. Now it's all bonus marks.
We start on AKT.
Start on AKT. Okay. 4 drugs.
3 drugs, sir.
3 drugs. AKT for what?
Non-pulmonary tuberculosis. No, but it has changed to 4 drugs now, sir.
So 4 drugs.
4 drugs.
We have to start.
4 drugs. We want, if you use the word AKT, now it will be 4 drugs.
4 drugs. Yes.
There is no doubt about that.
Extrapulmonary tuberculosis is there, so we have to add 4 drugs.
Extrapulmonary, pulmonary, whatever, the new RNTCP or what is called as NTEP, will say 4 drugs. What we did, I'll just share with you. We repeated a sputum for gene expert. We did a CT scan chest. And why did we do CT scan chest here?
For mediastinal lymphadenopathy, sir. See?
Yeah, so we wanted to be sure that whether there is pulmonary tuberculosis or not. This is not guideline based, but if you are thinking of non-tubercle mycobacterium, the duration of treatment is different if it is extrapulmonary or pulmonary. And if it's pulmonary, small ones can be missed on X-ray. We still started on 4 drug first line treatment till confirmation because this takes a long time to come. So we did start on 4 drug and we waited for the MGIT culture to come in, which came, and then the PCR testing, etc. were done. But the question here is, if we did a full excision, then no treatment is required for NTM. Okay, if there were no other lymph nodes. So we continued this till we got sure that we are not dealing with anything else. And then when the culture grew this, we could stop the treatment. But if excision was not done, what is the medical line of treatment? Any thoughts on that? I just need 2 minutes more.
Just we have to continue AKT, sir.
Okay, so I'll just share with you, because none of us routinely see NTM, and I'm sure once you think about NTM, that itself is full marks. You can always go back and check what drugs are required and what are the current recommendation. So just to share with you, one macrolide and one other drug at least has to be used. Sometimes even 2 AKTs are used. First, most important is you have to rule out Mycobacterium tuberculosis and treat both till you get the diagnosis. Okay, so we are in that IPL system, so just thought I will add power play over here. You already said about clinical. So what are the clinically to differentiate? If the lymph node is having an overlying skin which is shiny and query fluctuation is there, then you think it may not be Mycobacterium tuberculosis. So if it looks like presentation is like TB but looks like bacterial, then you think about NTM. Mantoux versus IGRA discordance we discussed. Gene expert versus stain, AFB stain we discussed. Management and drug treatment we discussed. These are just some of the worrying signs on lymph node. I will not dwell into that. Just wanted to say a big thank you to all of you from Mumbai IAP and Nanavati Max Super Speciality Hospital. Thank you and congratulations, Hingoli team. You have done a wonderful job.
Thank you, sir. Thank you.
If somebody put this case to me, I don't know whether I would have done a job as good as yours. So congratulations.
You are expert, sir.
Thank you.
Thank you, sir.
Thank you so much, Tushar Maniar sir, for such an interesting case presentation and discussing each and every diagnostic approach in detail, and also enlightening and stressing on the notification part. Can I have our expert's opinion, please? Dr. Rajendra Vaidya, sir.
Hello.
Yes, sir.
Can you hear?
Yes, sir, we can hear you.
Yes. Congratulations, Tushar, for excellent presentation, and again, great congratulations to Hingoli team. They have at least done a wonderful job by showing their approach, and it was a rational approach. I think Tushar must be happy what they have done. Interestingly, a very nice presentation and approach also.
And they only one or two diagnosis as well, right? So just
yes, as well, correctly, absolutely. Only thing is in the history, I think in first we should ask about the animal contact that they have done in the latter part, and in differential diagnosis before coming to malignancy is okay, tuberculosis is also okay. I think with looking at the age, female child 8 year with isolated lymph nodes, not very other clinical pointers, I would have thought 2-3 in diagnosis of the Kikuchi also, because a little pre-adolescent single node with fever and no other constitutional symptoms. So just a DD, we should have kept with the biopsy and everything. You have proved that, but I think that should be additional. Otherwise, this was excellent. And just I want to ask Tushar about this. In NTB, I think they avoid pyrizinamide. Am I right, Tushar?
Yes, they use ethambutol, they use rifabutin, and if the sensitivity allows, then mostly the drug of choice is clarithromycin or azithromycin, one of them, and along with them rifabutin and or ethambutol.
Yeah, they try to avoid pyrizinamide, particularly in that. Otherwise, excellent. Congratulations to both moderator and team also. That's the take home from my side. Excellent.
Thank you very much. I purposely avoided Kikuchi because that has become like, you want to always think about it, but not see it often. I was very tempted to put up a Kikuchi case, but then I thought, let's not get there. We don't see
third or fourth differential, not in the
No, I agree. We should always keep it in mind. No doubt about it. Thank you once again. Thank you.
Yes, thank you.
And jail term of 6 months to 2 years. Jail term of 6 months to 2 years.
Yeah.
If not notified. Not notified.
Yeah. Over to you, madam. Madam.
Unmute, Dr. Sunita.
Okay. Okay. So I think without wasting time, we will go to the next case presentation. So the next case presentation would be by Dr. Vipul, and it would be for Kolhapur team. Kolhapur team, unmute, and Vipul, Dr. Vipul, can you please share your presentation?
Yeah. Good evening, everyone. Without wasting the time, I am just starting with the case. Yeah. So this was a 12.5-year-old female child. She was brought to us with a complaint of breathlessness for 5 days and swelling, which was noticed over face over last 5 days. So she was apparently all right 5 days back when she developed acute onset swelling over her face. Swelling was more in the morning while waking, and the swelling lastly now for last 3-4 days it has progressed, and now it is also noticed over the legs. She also developed breathlessness 5 days back. Okay, and on day 1 of breathlessness, she experienced that on day 1 of illness she experienced a breathlessness which was at rest. It was associated with some chest pain, and sleep was also disturbed because of that chest pain. And now the breathlessness intensity has gone down, but swelling has progressed over the last 5 days. In the past history, there was recurrent episodes of cough between 1 to 5 years of age. All were without fever, never admitted for breathlessness in the past, but she has received nebulizations and inhaled steroids for the same. Rest of the history is uneventful. Birth history normal. She was the eldest sibling among the three.
12 years.
No family history of any major illness. Okay. So what is your thought process? You want any more information on this?
Go to first slides first, please.
Yes, definitely. So she is a 12.5-year-old female.
Yeah.
And brought to us with a history of last 5 days, complaint of breathlessness and swelling.
Breathlessness means there has to be some respiratory, cardiac, or renal, or some allergic phenomena. Okay, without fever means non-infective cause of breathlessness. Okay, but does she, and swelling also over face initially.
Yes.
So swelling over face we think of renal, but here against renal is breathlessness. So with breathlessness and swelling, we should go for allergic phenomena. Or is there a history of anaphylaxis, or he has taken some drugs somewhere and that has caused, and she has a recurrent episodes of cough in between 1 to 5 years, where but never needed admission. So whether this cough was there, what was the cause of that cough, and there was a wheeze, we want to know whether she responded to nebulization or she responded
in the past probably it was associated with wheezing all the time because she received nebulizations and inhaled steroids for the same. This time her complaint is breathlessness. There is no history of cough.
Is there
any history of fullness of the neck now?
No.
So this time breathlessness must be because of that swelling, edema, and we have to combine this breathlessness with that swelling. So, and without cough means there is no airway involvement at this time, but there is a chest pain. Chest pain, breathlessness, and swelling means she must have some pleurisy or large pleural effusion must have happened. That's why she is breathless. We want to know whether she was exposed to something else and she has episodes of allergic in this past, or she has food allergies there or something like this.
Also, sir, you said she is breathless at rest also.
She was breathless at rest on day 1 of illness. She had chest pain with that breathlessness on day 1 of illness, but now the breathlessness is gone. She is otherwise comfortable and the swelling has progressed. Swelling over the body has progressed. Secondly, the chest pain was only on day 1. She woke up from sleep because of the chest pain, but now there is no chest pain for last 4 days.
Whether the breathlessness was acute in onset or was insidious in onset?
It was acute in onset. On day 1, she was sleeping and she woke up from sleep, and she told the parents that she is breathless, she is having chest pain, and because of that she is not able to sleep.
Whether the facial swelling is limited only to the face or it is involved in the neck also?
No, it was noticed first over the eyelids, means it was the more of a periorbital puffiness. It is still there, and now the swelling has progressed. Now the swelling is over the legs also.
Neck.
No neck swelling.
Okay, we can divide this into breathlessness and swelling per se. If there is swelling, means edema is there, it has to be a renal origin or cardiac origin because she has breathlessness. But as you have said that it is acute in onset, cardiac is less likely, because whether there is a history of easy fatiguability in the past or something like that, we want to know.
And the breathlessness
And
has decreased now.
third point is whether it is an allergic type of edema.
On leading questioning, mother told that last 6 months she has noticed that progressively the activity of the girl is getting down. She is she is not active as it was previously, but it has happened gradually over last 6 months.
Yeah, this tells that it is a chronic process rather than an acute process. Then we'll shift our focus from renal allergy to the cardiac point of time. Yeah, cardiac origin, because it is a breathlessness and edema points towards the cardiac origin.
Any further information you want to
We would like to know much more. We would like to know much more.
On history.
On history only. Whether she has a fever in between last 6 months now.
No
Because story starts from last 6 months.
No fever.
Means less likely to be infective cause or very chronic illness which can cause without fever also she may have. But we like to know about that, and we have to like to document about fever. You know, put yes. Is there any history of rash over the body?
No history of any rash over the body.
History of abdominal distension or
abdominal distension?
No.
Pain in abdomen?
No.
Okay.
Is there any history of
Palpitation?
Is there any history of contact with the open case of Cox?
No history of Cox contact.
History of palpitations, sir?
No history of palpitations.
I would like to know about personal history. What was his diet? And last 6 months, how she was? You said that she was weak and she gradually, progressively increasing dyspnea. But we like to know more about
diet was fair. As we took the nutrition history, the calorie deficit was around 300 kilocalories and protein deficit around 8 grams.
And what about, is there a history of loose stools?
No history of any loose stools.
No history of loose stools. Okay. Personal history, family history, does this have something, somebody suffering from the same like this?
No history of any similar complaints among the family members. She is the eldest sibling. She has got 2 more siblings. One is a male child, another one is again a female child, and both of them are pretty okay.
Okay. Diet is, she's deficient in diet, no? You said she's
around 300 kilocalories deficit and 8 grams protein deficit.
Okay, but 12 years is okay. Will not.
So that's why I told the diet is fair.
Is there a history of jaundice?
No history of jaundice.
Okay. No history of rash. No history of jaundice. No. Renal urine output is good and there is no hematuria.
Yeah, no history of any decreased urine frequency. Okay, no history of any hematuria, definitely.
Okay, means on history we probably rule out liver as a cause of jaundice, but it can present like this. Chronic liver cirrhosis can present like hypoalbuminemia and can cause like this, but it is less likely now because there is no jaundice is there. Renal parameters are good and acute onset, and with breathlessness we still can think of, but cardiac is more likely now, as you said.
Dietary we have ruled out almost.
So 4 or 5 domains of edema we are thinking like this.
Is there any history of increasing pallor that the
For
feel?
that breathless and edema?
Mother has not appreciated it.
Mother has not appreciated any increasing pallor.
Any pallor, but will come to know on examination.
Okay. So we'll be interested in that.
So now
Yeah.
only thing remaining is cardiac problem.
Cardiac
So,
or what?
renal.
And cause of that, it may be secondary to something else. Cardiac may be there, but it may be secondary to something else.
Okay. So on general examination, she was conscious, alert. She was, sorry, spell miss. She was afebrile. Pulse rate was 114 per minute, regular, bilateral, equal, good volume, in fact, bounding. And there was no radial or radiofemoral delay. Respiratory rate was 28 per minute, but no retractions. Blood pressure was 126/70 mmHg. Peripheral pulses hemodynamically was stable. There was severe pallor, generalized anasarca, some clubbing.
Okay. In this, you are given a clue that there is a severe pallor. Means
Yes.
pallor may be the cause for his congestive cardiac failure and severe weakness and persistent fatigue for last 6 months. Clubbing is there. Yeah. And now clubbing with pallor, with breathlessness. Okay. No icterus, cyanosis, lymphadenopathy, rash. So others are ruled
Can
out.
we go to systemic examination?
What?
Clubbing is there means we can think of respiratory, but you are not told about respiratory symptoms as such, because chronic obstructive, no as such. So we are not
No.
thinking of that.
She's asymptomatic. She's asymptomatic for last 7.5 years. She had last episode at 5
We
years
can
of
think
age.
of inflammatory bowel disease or liver problem for this clubbing. Out of that, or systemic examination for what is the cause of severe pallor, we want to know. Now we'll search for that.
Anthropometry, sir.
What?
Whether there was some,
we are going on anthropometry.
Okay.
So
whether there was some black color stools in the past.
no history of any black colored stool in the past.
Pain in abdomen, not. No
No.
arthritis.
No.
Okay. And
So-
it is a gradual process over the last 6 months, no?
Yes. So
Height.
height is 141 centimeter between 3rd and 10th centile. Weight was 27 kg, which is less than 3rd centile, and expected weight for height is around 34 kg.
Okay.
So systemic examination.
Acute on chronic process.
Yes. In systemic examination, rest systems were normal. On per abdomen, liver was palpable around 5 centimeter below costal margin. Soft inconsistency, non-tender, but liver span was again normal, around 8 centimeters.
JVP raise? JVP raise?
No, it was normal.
It was normal. JVP was normal. And still liver is palpable. And there is no span normal. Okay. 8
Span
centimeter
is-
span is normal then.
Yes, yes.
Okay.
Any more information you want?
Yeah. Now, from your history and systemic examination or general examination and systemic examination, we come to know that there is severe pallor, edema is there, and she was breathless, and clubbing was there. So now we have to fit whether the anemia, clubbing, and breathlessness fits in. Clubbing, there is hypoxia, continuous hypoxia is there, low grade hypoxia, and that's why there is a clubbing. So interstitial lung disease can be one of the thing where she was repeatedly, history of wheezing was there, and she has now come with that. So we want to know whether the oxygen saturation was normal in this case.
Oxygen saturation was 92% at room air.
92% is less. Yeah, and she is chronically and without lung signs per se. She doesn't have any crepes. She doesn't have any wheeze. With hypoxia means it has to be interstitial involvement. Anatomy is interstitium, and we have to find out cause of that.
Correct. If we go through the causes of clubbing, it can be either respiratory, cardiac, or intestinal, miscellaneous causes, right? Idiopathic. So in respiratory, we have to think of chronic obstructive pulmonary disease like chronic bronchial asthma or
bronchiectasis.
or bronchiectasis. And in or other than chronic obstructive pulmonary disease, CA of
Say
lungs. Say bronchus. So that is rare in pediatrics, but we should think in this case. We should keep in mind, I think. And then cardiac, of course, there are no other cardiac systemic examination is normal. Cardiovascular system examination is normal.
Nothing.
Yeah.
So it was, she is a 12-year-old girl with acute on chronic malnutrition on anthropometry with severe anemia, okay, going into cardiac failure. Okay.
Cardiac failure is said, but JP was normal in this case.
Yes, it was what is the mention. Yes. So now we are on to investigations.
So why you say it is cardiac failure, but liver is within non-tender liver. No, a mildly tender may be there, but liver span is normal.
Normal.
Yeah. So how we can say that is season cardiac failure? Okay. Probably cardiac failure.
Yes.
Tachycardia was there, but tachycardia can be because of anemia itself. Okay.
So on investigations, her hemoglobin was 4.6, total count was 16,100, poly 68, lympho 25, platelet 3.47 lakhs. MCV was 46, MCH 12, MCHC 26, and RDW was high, 21.8. ESR was 36. Rest of the system functions, liver and renal, were normal, metabolics normal. And on peripheral smear, there was microcytic hypochromic anemia with anisocytosis, poikilocytosis, no abnormal cells.
Anemia with, in this case, could have bleeding.
Iron studies were suggestive of severe iron deficiency anemia. Iron serum iron was 12, TIBC was 330.
So this is a case of severe iron anemia basically, and severe iron deficiency anemia. And severe iron deficiency anemia in this case is not because of deficiency of iron or nutritional, as this case is of 12 years old. Okay. What was her economic status, and whether we can whether she is living in the slum area, we can think of coupon infestations.
No, financially good. Father is a teacher, mother is a housewife, but they live in Panvel area only, and from a good affording middle class at least.
Okay. And as it is from Panvel area, we don't see here in Kolhapur malarial cases. But what about this malarial parasite in your case?
No fever.
No fever, but
ES is negative for malaria. There was no history of fever.
Okay.
So is she losing somewhere?
So she is losing somewhere, or there is some gastropathy. Yeah, intestinal inflammation is there, and we have to find out the cause of it. But ESR is what? How much?
36.
36 only, not that great. Okay, to say that is a IBD disease, but there is some gastropathy causing, intestinal gastropathy or enteropathy causing, and that is causing severe anemia, and severe anemia causing maybe congestive cardiac failure, and that's why she was breathless.
She's not doing well since last 6 months.
Last 6 months, yeah. And her, if you relate this, her story of 1 to 5 years repeated respiratory tract infection, what we can think of? Ferritin is okay, severe and Ipsen.
1 to 5 years, there was no respiratory infection. She got just wheezing attacks.
Wheezing attacks. Okay.
There was no fever only.
No fever. So we can think of something like celiac disease or something.
Celiac disease can cause clubbing.
Yeah.
Okay.
Celiac disease. Or some other causes where we can think of. What investigation we like to do?
Yeah. What more investigations would you like to do?
First thing we'll do stool for occult blood for 3 days.
And stool for OI and cyst if they are there. That is a primary.
So we did celiac workup, which is negative. Stool is normal. Urine is normal.
Okay. TTG. Cyst.
Yeah, we have done TTG.
Okay, he says hypoxic also. Now you said 92.
Yeah, she is 92%. We're coming.
X-ray chest is there.
X-ray chest.
Let me see the X-ray chest.
We gave blood transfusion twice. Repeat hemoglobin was 9.3.
Yeah.
Okay, and the story begins here actually. So SpO2 is 92% on room air. Is it normal?
No, not normal. We already.
AV fistulas.
It is not normal. It should be more than 95.
What investigations would you like to do?
So find out the cause of that AV malformation can be there, maybe pulmonary to the aorta. Yeah.
What next investigations you will like to do?
We'll like to do first X-ray. What? Let me see the X-ray.
X-ray is standing.
X-ray is standing. Yes. Yeah. CP angles are clear. Cardiothoracic clear. Okay, not
Mild cardiomegaly can be contributed to that anemia.
Yes.
yeah,
Other
that's
than
all.
that,
Nothing is
other
there.
than that, there is nothing.
Okay. 1 minute. Go back.
Right parahilar congestion seems to be sometimes
Okay, not
AV
much.
fistulas can be present in that
Yeah.
area.
So you have to find out the cause of that hypoxia.
The ABG.
So this was the first ABG which we did.
ABG says there is hypoxia, pH is normal.
This is on room air.
This is in room air? Or
Yes,
we
room
supplement-
air. It's room air.
And no, not much metabolic acidosis. Okay, only purely hypoxic child
Okay.
without any acidosis.
So what next investigations you will like to do?
So we would like to do echocardiography first.
So we did hyperoxemia test first,
Okay.
and that improved the PaO2, but SATs were still not 100%.
Okay, there means right to left shunt is there in the pulmonary area, probably.
So we did 2D echo. So this is the 2D echo. Congenital heart defect, small sized ASD with left to right shunt, mildly dilated left atrium and left ventricle, no PH, no coag, no PDA, good biventricular function.
Dilated left and
Sir,
and what about the blood pressure? Blood pressure was normal.
126/70.
126 by 70. Okay, no, normal. Small size septal defect. SAB.
See, for a ASD, mild dilatation of left atrium and left ventricle is unusual. Because in ASD, you will get right atrium and right ventricle that will be enlarged. So here that is unusual.
And mild
So
small
now-
size ASD will not cause any dilatation as such. Okay, so
This
you have
is
to find
quite,
out. So
this is
it
quite
is
unusual.
hyperdynamic circulation, but with anemia, it will not cause left atrium and left ventricle to dilate such a great degree. So we have to find out shunt whether there is sub-shunt
we
somewhere.
need to go
Can we
with
do a contrast?
angiography.
Can we do a contrast?
But anemia, what is the cause of that anemia?
Can we have a contrast echo?
Anemia, we have to find out the cause of that anemia.
Contrast echo.
Angio.
So
So next one,
contrast
you want-
echo will be the next thing.
we did a contrasting. And after 3 cardiac cycles, we could see the contrast, which was suggestive of AV malformation. And we did CT and we confirmed it turned out to be a large AV fistula.
Oh,
That was the cause of plugging.
Yeah.
What is the cause of anemia, sir?
anemia, cause of
Yeah,
anemia.
we are coming to it.
Yeah.
What next?
We are not happy with only that AV fistula.
Yes.
Sir, because of
On-
anemia, we could not have that hypoxia which could have been severe.
Yes. So on leading questioning,
आपण बघितलं की.
yeah. So on leading questioning, we asked them, and then mother revealed there was history of episodes of epistaxis and some altered color stools in this child, and similar episodes are also present in the one of the sibling and mother also.
Okay, then there must be some pulmonary bleed inside. That's why she was breathless. Okay, that is called as.
She was breath
Can you go
Sir,
to the previous
slide,
slide?
please.
on. That's okay. Here they have mentioned something else. On leading questioning, we asked the mother again. So we again revisited the history where we got the history of repeated episodes of epistaxis and some altered stools. Though the mother, this child was already put on hematinics because of the some pallor which was detected in the prior clinical examination. and similar history is present in the sibling and grandfather and also in mother.
What is liver cirrhosis?
Pulmonary bleed होते की त्यामध्ये hemocytosis.
No, sir.
Pulmonary hemocytosis and causes of pulmonary, whether she has bled inside the lungs.
No.
You fistula पण telangiectasia पण आहे तिला.
Telangiectasia कुठं सांगितलं?
So you have said go back. What you have said, we are not. Go back.
So that will reveal the diagnosis.
Okay. Telangiectasia. The Castleback-Marriott syndrome.
नाही.
So we have to find out whether there are some AV fistulas somewhere else and they are bleeding.
Sir,
so that
do a HIV test for this.
Family history.
HIV test.
HIV we have not done in this case. See, this similar family history. Okay, this girl itself had past history of epistaxis and some altered stools. That was after we revisited the history again. After this whole thing turned to be, then we revisited the history, and she also revealed that there is similar episodes are happening in one of the sibling in the mother and grandfather.
Okay, so this has to be hereditary. So hereditary angioedema, but yeah, hereditary angioedema. C1q deficiency, sometimes present like this edema and breathlessness. Your first slide, edema and breathlessness. But anemia is not fitting into that.
Fistula is not fitting into that.
Yeah, AV fistula is not fitting into that. So with AV fistula and edema and anemia.
Hereditary AV fistula कुठं बसते पाहायचं. So we want to find out where in which hereditary conditions we have AV fistulas, right, sir?
Yes.
So we'll go back to test and find it out.
Yeah. So we suspected hereditary hemorrhagic telangiectasia and we sent a genetic workup which was positive, and it turned out to be a type 1 HST, which is happens because of the mutation in the ENG gene.
You had a case like this of the gut NICU. Yeah. The Apple has the similar case like this, whether they have all the intestine was telangiectatic and that child was continuously anemic.
In this case also, we did a scopy, but that was normal. That turned out to be normal.
Very good case, sir.
Yeah, thank you.
Thank you, sir.
Dr. Vipul, you can stop the screen share.
Google case. Okay, but good.
What is this Google?
Excellent case, Vipul, Dr. Vipul, and very like a good job done by Kolhapur team, wanting for more and to get to the actual diagnosis. Thank you so much. Congratulations to both of you. And I would want our expert to give his suggestion.
Yes, thank you and congrats, Dr. Vipul and Kolhapur team. Your approach was excellent. We are not interested in diagnosis. And what it again points, history is more important, like Ambedkar sir says. And go dig a history if you are not getting a diagnosis. Go for personal history, family history. Even they are not giving, then you have to actively ask, bleeding, let us what we have learned from this epistaxis and everything. And from first clinical clue, it was definitely that she was having some chronic problem and she's breathless and with related to orthopnea, like in the lying down. So there is some related with the cardiac and some pulmonology, apart from going for liver and kidney. I think it was excellently properly chart out and approach was good. I think that was more important. Even it was googly for me also, because we may not see such cases, but you can just think like a history where anemia, where losing blood in the lungs, in the kidney, because obviously these things we cannot see. Then we have to dig it out from where there is a loss of blood. Rarely we get like nowadays iron refractory, iron deficiency anemia, all these rare diseases, but they don't present. They present only the anemia. When there are dyspnea, anemia, plus they are having some clubbing, which again pinpoint to the some chronic illness which is going on with some additional like a SpO2 is persistent, pulmonary interstitial disease, we might get such kind of presentation. Cystic fibrosis we might get, but presentation is since beginning. It's for first 5-7 years, she was absolutely normal. So I think excellent presentation, excellent way out you got. And history, again, history is more important. I think we should learn from this. We should dig the history vigorously and properly. Again, I congratulate to moderator and team. Thank you very much. Over to you, madam.
Mohite sir, will you want to add some points?
Nothing, actually, both were very interesting cases. First case by Dr. Tushar gave us the highlights on a non-tuberculous this is lymphadenopathy. It was really a good lesson, but the Hingoli team did equally well. And about the second case, I must congratulate Kolhapur team for a wonderful approach. Absolutely wonderful approach. I mean, they really took everything dissected well, but they reached the pulmonary AV fistula. I really compliment you. Wonderful job done. Absolutely. I think getting it into that at the end, once you have that epistaxis plus pulmonary AV fistula, which was detected, and then some hemoglobin loss with a dark color stool, you could have taken it from GI, and then multiple sites of vascular anomalies, whether it is, and that's how you may be coming to hereditary hemorrhagic telangiectasia. As though I agree, as Dr. Vaidya sir said, it's not something which we say day in, day out. But again, this forum is not for the day-to-day absolute routine things. There should be something challenging. That's how this case was taken. But I think Kolhapur team wonderfully did well. Both the teams, hats up to you. You did a wonderful job.
Thank you.
Big applause to you. Thank you very much. So over to Dr. Sunita and Dr. Hemant.
Just one thing I want to ask Dr. Vipul. Dr. Vipul. Hello.
Yes, sir.
Have you thought of doing RBC technician scan, label technician to see from whether the talent is bleeding? Have you thought of or tried that?
No, sir. We just did scoping, and that was turned out to be normal. We didn't did RBC technician scan.
Because sometimes if there is a loss is not visible from intestine or lungs, sometimes they do the RBC and they pick up the various bleeding sites. I think that is in the tertiary care, but that is one more to detect some hidden bleeding.
Okay.
So, thank you.
Thank you, sir.
Hearty congrats to both the teams, Kolhapur team and Hingoli team. Well done.
Yes.
Dr. Gangulia sir, you want to say something? So now,
Is there? Yeah.
Both teams well done.
Yes.
Thank you.
Yeah.
पण अनिमिया एवढं 4 पर्यंत जाऊ शकतो का याच्यामध्ये? दॅट इज द ओनली whether it can go to up to 4.
The child must be bleeding.
Yeah.
But in lungs also he must be bleeding. There must be some
Low, I think low grade bleeding for a long time. That's why she manifested so late. She was compensated for a long time, and that's why she manifested so late. Some point of time decompensated, which was too late. But agreed, in chronic hemorrhage, low grade hemorrhage possible.
The hint for lung AV fistula was clubbing and hypoxia in presence of anemia, in presence of severe anemia, and the ASD which showed a left atrium and left ventricle, that was valid.
hyperdynamic circulation.
That was because ASD will always have a right atrium and right ventricle. That was the only clue that we could have.
Yeah, and hyperdynamic circulation has led to a lot of breathlessness, even AV malformation. With the hyperdynamic circulation, they are manifested after that.
We intended to diagnose AV fistula, AV malformation, and X-ray itself.
Dr. Tushar?
Congratulations, Kolhapur team. Very wonderful job. To be honest, in fact, in between when the case was on, I was thinking about a pulmonary hemosiderosis because of severe anemia,
and breathlessness.
intraventricular bleed with pulmonary fibrosis, with clubbing, and a borderline low SpO2, and a child who is then going into cardiac failure. That was my first thinking. But just to make a point again, now this is all hindsight, but on the X-ray, I'm not sure, Mahesh would know better. Was there a paraspinal shadow on the right side that, or whether we are now seeing because we know it's after seeing the CT scan? So that's possible. But congratulations, Kolhapur team. Wonderful to diagnose on hot seat. It's very important to think right on the hot seat. Thank you very much.
It was really hot. Thank you.
I mean, almost all sessions today so far, I think all the teams cracked. So
Yes.
4 sessions, 8 difficult cases. That only speaks of volumes of talent which is available all along, everywhere. I mean, academicians are there in every part of the state, and that only speaks of that. And I vouch, no one knew the case. No receiving team knew the case, and we make it very mandatory that no one gets any clues out of it. So this is the real talent that we see in the state.
We didn't know who was presenting. In the last minute.
I did not know that I was presenting.
For this, you can blame it to us.
अजून ट्रान्सपेंट करायचं असेल ना तर एपिसोडच्या सुरुवातीला चीट काढायचं, समोर चीट काढायची. अजून ट्रान्सपरन्सी होऊन जाणार की बाबा हे 2 चीट्स आहेत, हे प्रेझेंटर्स आहेत. हाऊसला चीट, येस.
नाही हेमंत एपिसोडच्या आधी चीट मी काढली आणि मी सुनीता मॅडमने सांगितलं ह्याचं याला द्या म्हणून मी ते
आपण समोर करूया, पुढच्या वेळेला आपण समोर करूया, समोर करूया. तुम्ही असणार आणि चीट तुम्ही काढणार, समोर करूया.
नाही, डॉक्टर महेश
बोला हाँ बोला
really like
हाँ बोला
we are digging in the history lot. Same thing we are digging in academics in all our colleagues by this Maha case challenge. Wonderful, excellent. The brainchild of your United Congress.
Thank you very much.
Thank you, sir. Thank you.
So we'll end the session, and I'll request Dr. Neha ma'am to give the vote of thanks.
Thank you, Dr. Shilpa. Am I audible?
Yes.
Go ahead.
Yeah. On behalf of Maha IP, I would like to thank Dr. Rajendra Vaidya sir for accepting our invitation, for being today's expert. Sir, your expert comments at the end of each session was very inspiring. I would thank both Dr. Tushar Maniyar sir and Dr. Vipul Patil for presenting such interesting and excellent cases for today. I would thank both the teams, Team Kolhapur and Team Hingoli, for actively participating, and both teams were equally wonderful, and congratulations. I would thank Dr. Mahesh Mohite sir, who is the backbone of this program, for always supporting all the academic Maha IP programs. So please continue with your support and guidance. I would like to thank our Maha IP President, Dr. Hemant Gangolia sir, and Secretary General, Dr. Amol Pawar sir, for giving us this platform. Thank you, Dr. Sunita ma'am and Dr. Shilpa, for moderating the case challenge. Last but not the least, I would like to thank all the attendees on Zoom and YouTube Live for joining us today. Thank you.
And technical support by Madam Pallavi.
Yes. Pallavi ma'am, thank you so much.
Thank you very much. Thank you.
Thank you. Good night.
Everyone. Good night.
Good night.
Good night, everyone. Good night.